Hello, my name is Eric Buckmiller, and today I will be covering an eval on a patient with lateral epicondylitis. To give you a brief etiology, epicondylitis is caused by repetitive microtrauma from overuse, targeting specifically the lateral epicondyle of the humerus and the lateral aspect of the elbow. For you to receive more information from your patient on their current condition, it'd be very beneficial to ask some good history questions, such as, where is the pain located? Your patient in this type of condition would be able to show you that the pain is more in the lateral aspect of the elbow. Another good question would be, when did the pain start? As this condition is more chronic, we may receive an answer such as a few weeks to a few months in the past. How would you describe that pain? Someone with this condition would describe this pain as an ache, not something sharp, more of a dull aching pain. Asking them their history of possible sports, such as, have you had any experience playing sports such as tennis, golf, baseball, Olympic weightlifting, something that involves rapid movement of the arm and the wrist? Having a positive or a yes from this answer or from this question may give us more of a direction towards an overuse injury. Asking them something such as, which movements cause and elicit more pain? Someone with this condition may state that elbow extension and wrist extension would cause more pain. After asking these history questions, we can gather some information and begin to think about a few differential diagnoses to consider, such as a radial collateral ligament sprain, or a radial humeral ligament sprain, or even a distal bicep tendon rupture. Having these differential diagnoses in mind, we can test for them later on in the future on this eval. We will then progress to our observations. In observing someone with lateral epicondylitis, we can even look how they are standing themselves. On their uninjured limb, we may notice that their arm is in full extension, whereas the injured side may be in slight flexion due to the pain that comes with elbow extension. Another thing we can check for is their Q angle. Someone in a normal situation would have a carrying angle, Someone with a normal carrying angle may have a slight cubitus valgus. We are looking for the decreased angle and almost a cubitus varus for the injured limb to give us a possible thought of an overuse or even an epicondylitis injury. Now, moving past, we can begin to look at BADs. In something such as lateral epicondylitis, we probably won't notice bleeding, atrophy, deformities, discoloration, spasms, or scars, but one we can notice is swelling in certain conditions. A good way to check for that is either observing the area itself or even having the patient flex their elbow to 45 degrees and looking to see if you can view the lateral epicondyle, the medial epicondyle, and the olecranon process, forming that isosceles triangle, which would also give you a different angle of view on that lateral epicondyle to see if there's maybe some inflammation. It is also good to compare these observations bilaterally with the uninjured limb to give you a starting point to see if there are any deformities or irregularities. We can then progress into our palpations, and specifically our bony palpations. Starting on the lateral aspect, specifically since this is where we're dealing with an injury, is palpating the lateral epicondyle. Someone with this condition would elicit pain on palpation. We can also check the radial head, seeing if there's any irregularities, and also the proximal radius. Progressing, we can move into our soft tissue palpations, checking the musculature around the area, such as the brachioradialis, or the wrist extensors, or even feeling deep for that radiocollateral ligament. Again, checking and testing for these bilaterally to compare their normal limb with the injured limb to see if there are any deformities or irregularities. After our observations and our palpations, we can then progress into our range of motion. With lateral epicondylitis, the two range of motions that are affected most and elicit deficits are elbow extension and wrist extension. Let's begin with the elbow, shall we? With elbow extension, something we can also look for in observing, but also testing in range of motion, is extension of the elbow. Normally, extension is 0 degrees, but in certain cases, people can hyperextend the elbow. To test that range of motion, we do not have a training or a testing table or a treatment table, but I'll have my patient kind of lean down more onto the table. I will place a solid object, smaller and round, underneath the arm, just proximal to the elbow joint, that way lifting the forearm off of the table. To test the range of motion, we can use a goniometer, using the joint to test the degrees of extension. So placing the axis on the lateral epicondyle of the elbow, the stationary arm against the humerus, and the movement arm on the radius pointing towards the styloid process, we can then have the patient attempt to move into extension. And as we can see, this patient has around 7 degrees of hyperextension of the elbow, which can be normal. From here, we can begin to test our active, our passive, and our resisted range of motion. We'll have the patient move through flexion and extension of the elbow. Upon extension, they will most likely elicit some pain. We can then stabilize the humerus and make the movement for them, which they may also elicit pain with us performing the movement. And lastly, we can perform resisted extension. We'll have the patient slightly bring their arm into flexion, and as I attempt to push them into flexion, she will attempt to push into extension, which may elicit pain and weakness. We can then progress to wrist extension. Again, because of the situation, I will move this so that we can at least get a good idea of the wrist extension. I'll have my patient actively bring her wrist into extension, which may also elicit pain. I will then have her relax her arm, and I myself will move her wrist into extension, which could also elicit pain. And then upon resisting, as she attempts to bring her wrist into extension and I intend to push it into flexion, there would be pain and weakness. Finally, we can progress to our special tests. We primarily want to test out those 3 differential diagnoses to make sure they are not a problem. First was the radiocollateral ligament sprain. To test that, we can do the varus stress test. In gripping the patient's arm, placing one arm on the forearm, the other arm up here on the humerus, we can attempt to shift that arm laterally, that elbow laterally, to see if there's any laxity or pain. Because we are not dealing with radiocollateral ligament sprain, we would not notice pain or laxity. Next we can test for is the radiohumeral ligament sprain, which we can use joint play to test that. Stabilizing the humerus with one arm, using your other hand, gripping the radial head, you'll use and try to move that joint around to see if there's laxity or if the patient is eliciting pain. Most likely there may be pain to the palpation, but not pain on the radial head, because this is not a radiohumeral ligament sprain. Finally, we will test for that distal bicep tendon rupture. I'll have my patient move into 90 degrees of abduction of the shoulder, 90 degrees of flexion, and then I will, using the hook test, try to hook that bicep tendon as she is trying to flex the bicep. As I can hook the tendon, there is no rupture of the bicep. To test this current situation, we would use the Cosen's test, which, having the patient's arm on the table, having their wrist in extension, I would attempt to push down, and as she attempts to push up, there would be pain in the lateral aspect of the elbow. This has been an eval of someone with lateral epicondylitis. Thank you.